Northwestern Medical School and completed his residency here at UW before joining our fellowship. He's excelled as a fellow and is currently serving as our co-chief fellow. And in this role, he's made numerous contributions to improving our training program for the current fellows and future fellows. He's looking forward to starting his career as a general cardiologist in Bozeman, Montana, where I know he'll take full advantage of all those amazing outdoor activities. Joining Alex today is Chris Chandler, who shares a name with a former Husky star quarterback. I might be the only one who noticed that. But he also attended medical school at Northwestern and even overlapped with Alex, and I'm told they ran together on the beautiful lakefront trail there. Chris is currently doing his fellowship as the inaugural cardiovascular and pulmonary pathology fellow, and he has an interest in medical education, and I know he and Alex have two fantastic cases for us this morning. And with that, I'll let Alex get started with our first case.
Excellent. Thanks so much for that very kind intro, Dr. Borman. I'm excited to be presenting with my friend from medical school, Chris Chandler, and we have two really fascinating cases to share with you this morning in Cardiology Pathology Conference. So I have no relevant disclosures to this talk. So our first case involves a 40-year-old man who has no prior medical problems. He presents initially to a hospital in Idaho with 3 weeks of chest pain and dyspnea. He works as a filmmaker. He quit smoking a few years ago. He has male sexual partners, and he really has a history of very extensive world travel. His mother had valvular heart disease. There's no other family history of cardiac disease. On his initial examination, his vitals are normal, and his cardiovascular as well as neurologic exams don't show any abnormalities. His initial basic labs are shown here, and they're essentially unremarkable. He had minimal elevations in his inflammatory markers, including the ESR and the CRP, and serial troponins were not elevated at all. So his ECG on presentation shows sinus rhythm with a left anterior fascicular block and no signs of myocardial ischemia. So he's referred for a coronary CT angiogram to better figure out the cause of his chest pain. And it reveals actually several abnormalities, which we'll walk through over this slide in the coming couple of slides. So this left panel here shows an axial image, right at the level of the sinuses of Valsalva. So what you'll notice here is he has an anomalous origin of the left coronary artery. So he has a common coronary ostium arising here from the right sinus of Valsalva. This is the right coronary artery coursing over this way towards the left of the screen. And this is the left main coronary artery. So it comes off and then takes this 90-degree bend where it actually dives into the myocardium. So it has this myocardial bridge segment here. And then I'll show the subsequent course of the left anterior descending artery on the next slide. The other notable finding is that he has a sizable aneurysm involving his ascending aorta and extending into zone 2 of the aortic arch. Zone 2 is basically the junction between the left common carotid artery and the left subclavian artery. And then there's also a suggestion of some thickening of the wall of the ascending aorta here. So this is raising the specter of aortitis. Here's some more images from his coronary CT angiogram. So this sagittal image here shows the origin of the left anterior descending artery. So this is sort of the ostial to proximal segment, and this is diving into the myocardium. So he has a myocardial bridge that involves the left main coronary artery and also extends into the ostial to proximal aspect of left anterior descending. The total length of this myocardial bridge of the LID is about 1 centimeter. This is a 3D volume rendered reconstruction of his coronary CT angiogram shown on the right panel. I thought this was a really nice demonstration of the course of the coronary arteries. So this is the right sinus of Valsalva here, which you see in the center of the screen. Let me see if I can bring my mouse up here. This is the right coronary artery taking its course. This is the long left main coronary artery, which then gives rise to the left anterior descending artery coming off here to supply the anterior wall of the heart. And then you see the circumflex system coursing posteriorly in this image. So to further characterize his coronary anatomy, he's referred for invasive coronary angiography, and we'll walk through that here. So in this areocranial projection, The catheter is basically sitting in the common coronary ostium with a sort of leftward bias to selectively inject contrast into the left coronary artery. And you'll see here, this is the left anterior descending artery coming off here. Hopefully you can see my pointer as I do this. Then this is the circumflex system, which takes this, this sort of a posterior course back into the AV groove. The sort of notable finding here is this sort of a dynamic compression of the ostial segment of the LAD. This right panel shows a freeze frame in systole when you see this marked stenosis of the ostial LAD segment. And this is the segment that corresponded to his area of a myocardial bridging on the coronary CT angiogram. So to further characterize this, this lesion, this ostial LAD lesion, he's referred for basically an invasive hemodynamic assessment with a resting full cycle ratio, also known as RFR. The RFR is essentially clinical, is basically the same as the IFR measurement, and the threshold for a significant lesion with both RFR and IFR is less than or equal to 0.89. So he undergoes basically a dobutamine stress on the cath lab table. And RFR is measured under baseline resting conditions prior to the start of the inotrope and also at peak inotrope. So under baseline conditions, the RFR is normal, but drops to a nadir of 0.6 with the basically inotropic stress. So there's this metric, and there's also dynamic compression of the ostial LAD noted on angiography. There was no evidence of ischemia across his left main coronary artery. And the conclusion from this study and putting it together with his coronary CT angiogram findings are that he has ostial LAD ischemia due to a myocardial bridge. I thought this was a really interesting image. So this is a parasternal short axis view from his transthoracic echocardiogram on presentation. And what you'll see here, we're right at the level of the aortic valve here. And then this is the right sinus of Valsalva, this top cusp here. So you can see it sort of comes in and out of plane, but this is the common coronary ostium. And then coursing to the right, which is our screen left, is his right coronary artery. And then coursing to the right, which is the right side of the screen, but towards the left is his left coronary artery. And you can see coming in and out of plane, actually, some of the intramyocardial segments of the left main coronary artery here as well. The other thing that I'll call your attention to is that he has a trileafed aortic valve that appears to open normally and doesn't leak at all either. So he goes for a cardiac MRI to further characterize his ascending and aortic arch aneurysm. And the key findings here, this basically doesn't add much information to his the coronary CT angiogram that I showed earlier, but the thing of note is that this process does not appear to involve the descending aorta, shown here on the right panel. And as we saw both from his echo and from the CT angiogram, the sinuses of Valsalva are spared by this aneurysmal process. So in light of all these findings, he undergoes surgery with Drs. Burke and Mockley. And intraoperatively, they note marked inflammatory changes of his ascending aorta and aortic arch with sparing of the aortic root and aortic valve. He undergoes an ascending aortic and zone 2 aortic arch replacement, as well as a myocardial bridge repair with a pretty extensive myectomy carried along the course of the left main coronary artery and the proximal LAD. And due to uncertainty intraoperatively about whether the bridge had been fully fixed, he was also given a prophylactic bypass graft with a Lima to LAD. And so after he undergoes surgery, these tests come back. So, in the course of his initial workup, several serologic tests for different causes of aortitis had been sent. And so this finally came back, and it turned out that he actually had syphilis. And we'll walk through serologic testing for syphilis on one of the upcoming slides. But to walk you through these results, his treponemal test, which basically looks for antibodies directed against treponema palliatum, was positive. And then his non-treponemal test, which is sort of the second test in this algorithm, was positive at a pretty high titer of 1 to 32. And then his other workup for potential causes of aortitis didn't turn anything up. He had negative blood cultures, negative serologic testing for these organisms. And then recognizing the high rates of co-infection of syphilis with other sexually transmitted infections, he was also tested for HIV, gonorrhea, as well as chlamydia, all of which were negative. So at this point, I'd like to turn the discussion over to Dr. Chandler to walk us through some of the histopathology and gross pathology from this case. So with that, Chris, I'll stop my share briefly and let you take over.
All right, thank you, Alex. I'm going to start sharing screen here. And thank you for letting me join this conference. This is going to be a lot of fun, really interesting cases today. So similar to Alex, I have nothing to disclose today. And I'd like to start just by looking at the surgical specimen, the histopathology for the surgical specimen of the aorta in this case. We've got a couple of slides to look at. And what you'll be seeing is it's called a whole slide image of the slide. So it's a digital scan, high resolution, which we'll look through. So just for orientation, this is the intimal surface of the aorta, and here's the adventitial surface. And from this very low power view, a couple of things are apparent. One, the aortic wall is quite thickened, so correlating with the imaging findings. And there appears to be some degree of fibrosis or some other expansion of the intima. Also, the adventitial surface has some post-procedural changes, the hemorrhage, but there's quite a bit of blue, which from a low power to a pathologist, we think, okay, that could be a few things, one of which is inflammation. So if we zoom in a little bit closer and look at this case, it becomes apparent from this kind of medium power view that it is, in fact, a very dense inflammatory infiltrate. It's centered sort of on the outside of the aorta, involving the adventitia and extending a little bit in towards the media. And it's even forming some secondary lymphoid follicles here. So it's infiltrate that's been there for some time. It's a germinal center here. And if we just kind of zoom around a little bit, it appears that it may have some association with some of the vasculature of the vasa vasorum. And if we look a little bit closer at the infiltrate, we get a better sense of what the inflammatory cells are made up of. So we've got a subpopulation of these small, round, little blue cells. These are lymphocytes, but then a fairly significant secondary population of these cells here, which are plasma cells. So it's a lymphoplasmacytic infiltrate. This is a plasma cell, has this sort of soccer ball looking nucleus. And that's the kind of predominance of this inflammatory infiltrate is lymphocytes and plasma cells. So the other major inflammatory cell that we're looking for in cases of aortitis is whether there's any sort of giant cell type of reaction. And I won't belabor the point and go through the whole slide, but we didn't find any giant cells within this inflammatory infiltrate. So lymphoplasmacytic sort of centered on the outside of the aortic wall. And then as we move in towards the media, which is here, and intima, we start to notice that there are areas that look a little bit different. They've lost their kind of cellular characteristics, lost nuclei. And in fact, these are areas of necrosis, fairly significant large zones of necrosis involving the media as well as the intima. So this is consistent with endarterectus obliterans, or this kind of overall pathology. And we can get a sense of what it's actually doing in terms of the obliteration part by looking at an elastic stain. So this highlights the elastic fibers of the media. And as a comparison, just to get a sense of how unusual this aorta is, this is a section of a normal aorta. So this is about how thick the intima should be. And here's kind of a normal elastic fiber layout. And again, from low power, you can see we've got a markedly expanded aortic wall. And there's areas where the elastic fibers have been more or less completely disrupted. So this explains why there's aneurysmal dilation as you lose the elastic fibers due to inflammation, as well as necrosis. You lose the elastic recoil and the aorta kind of dilates over time. So those are the main histopathology findings in this case. And just a little bit about syphilitic aortitis. So as is in this case, it's typically limited to sort of the proximal or ascending aorta. And grossly, what's been described in textbooks and historically is this kind of tree bark appearance of the intima. We've already kind of walked through most of the microscopic findings, but it's very characteristic in this case. So lymphoplasmacytic infiltrate involving the basovozorum and extends to the media. Often will have some medial necrosis and intimal fibrosis. Now, we didn't find any in this case, but you can have giant cells, but they shouldn't be the dominant finding. Sometimes they show up as areas around the regions of necrosis, kind of palisading histiocytes, which are called microgummas. And very rarely, can you find the treponema organisms by silver stain or immunohistochemistry. It's something we didn't undertake in this case just because it's not usually a high yield. So based off of the pathology findings, microscopically, there's a few things that come up on our differential. We really need to compare with the clinical history and other findings to try to narrow things down. Takayasu's aortitis would be something that we'd think about, although this tends to have more giant cells than what we're seeing here. Ankylosing spondylitis can present very much with this same sort of picture. And so again, correlating with any sort of clinical signs and symptoms. And IgG4 disease, due to the predominance of fibrosis, but also plasma cells, is on the differential. In this case, we actually did staining for IgG4 to look at the plasma cell populations, and it didn't support this as part of the diagnosis. So this is not from the present case, but this is a really nice example from the literature showing what the tree bark appearance of the intima looks like. We've got 3 or 4 different gross examples here. The top 2, you can see this sort of white thickening fibrosis of the intima overlaid with these yellow kind of patches. Those are actually atherosclerotic plaques in addition to the background fibrosis, whereas these bottom 2 have more just fibrosis, which is sort of patchy and causes wrinkling and leads to this classically described tree bark appearance on gross pathology. And these are what the treponema organisms look like by a couple of different methods. Sometimes we do these in other areas of the body a little bit more. Warthin-Starry silver stain, this is at 100x magnification. These small little spirochetes that are embedded in the inflammatory infiltrate. And then immunohistochemistry, there's a couple of nice IHC antibodies against treponema can be used as well. So this is what they look like, again, not pursued in the present case. So with that, Alex, I'll turn it back over to you.
Thanks so much, Chris. That is truly fascinating. So I'll walk us through a few more slides on syphilis and syphilitic aortitis. So this is a dark field photomicrograph of what those spirochetes look like. So this is, of course, the causative agent of syphilis. And unfortunately, syphilis has really become a sort of a resurgent public health issue. So in the United States, cases reached basically a nadir in the year 2000. And since then, they've been steadily increasing. This graph shows the time horizon from 2010 to 2019. And you can see that total syphilis cases have really just been going up over that time period. And in terms of the distribution of syphilis cases, one thing that came out from the recent CDC surveillance data is that men who have sex with men do face a somewhat disproportionate burden of syphilis infection. And based on this disproportionate burden, the recommendation is to screen even asymptomatic men who have sex with men for syphilis, just to make sure that it doesn't go untreated. So let's talk a little bit about serologic testing for syphilis. This is often a point of clinical sort of a confusion. So the traditional algorithm is what was done in the past. Most labs these days use what's called the sort of a reverse sequence algorithm. So this starts with the treponemal test, which looks for antibodies directed against treponema pallidum. There are a variety of treponemal tests that are used. And the key with this test is that it tends to stay positive for the lifetime of the patient. So basically it tells you if they were exposed to syphilis at some point, but it doesn't tell you if they've been previously treated or not. That's where the non-treponemal tests, which include the VDRL and the RPR, as was used in this case, those yield a quantitative result, and that can help give you a sense of whether they have active infection or if they were previously treated. In these cases, it's very important to know what the patient's baseline titer was if they have a prior history of treatment for syphilis. And what's used to basically, as the definition of successful treatment, is a 4-fold decrease in the titer of the non-treponemal test. And so we'll talk about that a little bit more coming up here. So classically, syphilis progresses, syphilis when untreated progresses through 3 stages of disease. So starting with primary infection, which is usually, sort of the presentation just with a solitary painless ulcer. If that's left untreated, that typically goes away. And then the patient progresses to secondary syphilis, the most common manifestation there being a sort of a widespread rash. And then with a longstanding untreated disease, the tertiary manifestations of syphilis, which include gummatous involvement, neurologic involvement, as well as cardiovascular involvement, as in the present case, start to manifest. One important thing to recognize that this diagram points out is that findings of neurosyphilis can actually manifest at any stage of disease. Classically, we think of tertiary syphilis having the neurologic complications, but it can really happen even within several weeks of the primary syphilis infection. So the takeaway here is that really any patient who has a diagnosis of syphilis who has new neurologic findings should, the possibility of neurosyphilis should definitely be considered. So as Chris very nicely pointed out, the primary histopathologic finding is this endarteritis obliterans, which is the vasculitis of the vasa vasorum. The archetypal finding is ascending aortitis that typically involves the aortic arch. Coronary osteal involvement has also been reported. I have not seen involvement of the more distal coronary arteries. In an autopsy study of patients with syphilitic aortitis, the ascending aorta was universally involved. The aortic arch was involved in 91% of cases. In this case series, the descending thoracic aorta was involved in 90%. However, that's substantially higher than other reports. So I think a takeaway here is that the primary involvement with syphilitic aortitis is of the ascending aorta and extending into the aortic arch. So how is syphilis treated? So this is from the CDC Sexually Transmitted Infectious Treatment Guidelines, which were published late in 2021. And so their recommended regimen for tertiary syphilis, and this is with the caveat that patients do not have evidence of neurosyphilis, is basically benzathine, penicillin G, given as 3 doses at 1-week intervals. The guidelines do recommend a CSF examination in all patients who are found to have tertiary syphilis. That wasn't performed in the present case, but certainly if the patient had any new abnormalities on their neurologic exam, that would have been indicated. So this is the treatment regimen. As I alluded to earlier, what we're looking for on the non-treponemal test, which would include the RPR, is a 4-fold decrease in the titer after treatment. That's considered an adequate response. And this RPR titer is reassessed at 12 months for early syphilis, so for primary, secondary, or early latent disease, and 24 months for late syphilis. So the plan in this patient who had tertiary syphilis, which is a form of late syphilis, is to recheck the RPR titer at 24 months to make sure that his course of penicillin was successful. If the patient does have neurosyphilis, then the treatment regimen does change a little bit. Instead of intramuscular penicillin, the recommendation is for IV penicillin G, either as a continuous infusion or as intermittent bolus dosing for 10 to 14 days. And I just show this chart here, not to walk through all of the potential manifestations of neurosyphilis, but just sort of to make the point that neurosyphilis can really present at any stage of disease and has many different potential manifestations. Just to briefly talk about myocardial bridge, because this patient had a bridge involving the left main as well as the proximal LAD. This is actually a surprisingly common finding at autopsy with a prevalence of about 33 to 42%. The most common location is basically what was found in this case, which is the proximal and extending the mid LAD sometimes. And in contradistinction to atherosclerotic lesions, Myocardial bridges are really this dynamic stenosis that varies with the phase of cardiac cycle, heart rate, and sympathetic tone. The challenge in evaluating and treating myocardial bridges is that the vast majority of these lesions are asymptomatic, but there is a small subset of patients who do experience symptoms from their myocardial bridges. Some of the factors that are thought to increase the risk of symptomatic presentations include deep bridges, so at least 2 millimeters, or very long bridges with at least 2.5 centimeters segments. Our patient had neither of these high-risk findings. And so then to further characterize these lesions, you can do what was done in this case, which is a stress test. This is a figure from a recent article in JACC looking at sort of management of myocardial bridges. I won't walk through this whole figure, but they present sort of several different options for sort of further testing these myocardial bridges. The standard of care is usually to characterize the extent of the myocardial bridge with a coronary CTA, so with this anatomical imaging, and then to figure out if it's functionally significant, you can do things like IFR, FFR, or RFR, or you can just do a stress test. The sensitivity of the non-invasive modalities tends to be less than these other metrics of coronary flow. One interesting point is that invasive hemodynamics, in this study, the diastolic FFR does correlate with stress echo findings in patients who have symptomatic myocardial bridges. So this figure is from a study that investigated 60 symptomatic patients who had myocardial bridges involving the LAD with at least 50% systolic compression. And I'll call your attention to panel D here. So these patients were evaluated with exercise stress echo at baseline, and those were scored as either positive for myocardial ischemia or negative for myocardial ischemia. And then they underwent a conventional FFR measurement in the cath lab and diastolic FFR during infusion of both a vasodilator as well as an inotrope. And in response to the inotropic infusion, after they basically looked at the diastolic FFR, and what you're seeing here is that these green circles show the stress echo negative patients, so no evidence of myocardial ischemia, and the red circles show evidence of myocardial ischemia. And the investigators used a diastolic FFR threshold of 0.76 to define myocardial sort of ischemia in the study. And you can see this nice separation of curves here. So the point here is that these sort of invasive metrics of coronary flow, such as the diastolic FFR, correlate with the stress echo, sort of a non-invasive findings in patients with symptomatic myocardial bridges. Just one slide here on treatment. The mainstay of therapy for myocardial bridges is basically beta blockade or calcium channel blockade. Calcium channel blockers are especially efficacious in patients who have vasospasm as part of their presentation. One point to make is that nitrates may actually exacerbate symptoms in myocardial bridges. The thought here is that nitrates may dilate the segments surrounding the myocardial bridge, which can lead to sort of this retrograde flow. They can also lead to a reflex tachycardia, which of course truncates diastole and then can worsen symptoms. The gold standard, though, for truly symptomatic patients is what our patient received, which is a surgical myotomy. This should be considered as first-line treatment with the caveat that it's performed at experienced myotomy centers because it is a technically challenging procedure to perform. The last couple of slides for this case involve the management of coronary artery sort of anomalies. So this is a figure from Dr. Stout's ACHD guidelines from 2018. And I'll call your attention to the left panel here. Our patient has a left coronary artery arising from the right sinus of Valsalva. And he had symptoms of myocardial ischemia and also had a positive stress test. So that renders a class 1 intervention for surgical, or a class 1 recommendation for surgical intervention. The goal of surgery in these patients is really to alleviate symptoms and also to reduce the risk of sudden cardiac death, recognizing that this particular coronary configuration, the left coronary from the right sinus, confers a higher risk of sudden cardiac death compared to the right coronary from the left sinus. And I'll show a couple of high-risk features associated with coronary artery sort of anomalies on the next slide. But these include an intra-arterial course where the anomalous coronary passes between the sinuses of Valsalva and the pulmonary artery, an intramural course where it passes within the wall of the aorta, a fish mouth shaped orifice, as well as an acute angle takeoff. So these are some nice examples of some of those potentially high-risk features. This left panel shows the interarterial course of the left main coronary artery coursing between the sinus of Valsalva and the PA. This is a schematic showing an intramural course of this coronary artery. And this is another coronary CTA-based example of an acute angle takeoff of the coronary. Last slide here on this case. This is a commonly cited paper from Dr. Eckert and colleagues. So they looked at basically military recruits who were undergoing basic military training, and they had a database of 6.3 million patients here, and they investigated 126 non-traumatic sudden deaths, 86% of which had some, basically either occurred during exercise or right after exercise. Strikingly, most patients who died in this series had no premortem symptoms. And of those who died in autopsies, 51% were found to have structural heart disease. And as you see here in table 3, the most common finding in those with structural heart disease was coronary artery sort of abnormalities. And the most striking thing here was that all of those who had these coronary anomalies had the left off the right configuration with an interarterial course. So this is really felt to be the sort of highest risk finding in these patients. All right, excellent. So our second case is a bit shorter, but is equally fascinating, and I'll jump right into it in the interest of time. So this involves a rare cause of dyspnea and chest pain. So we have a 35-year-old woman with a past medical history of basically just obesity. She's presenting with dyspnea and pleuritic chest pain that radiates to her left shoulder, and this has progressed over the last 2 to 3 months. She's found to have a right atrial mass, as well as a large pericardial effusion leading to cardiac tamponade. She's never smoked, does not use any drugs, and there's no family history of cardiac disease or cardiac tumors. At her index presentation, she undergoes an urgent pericardiocentesis. The pericardial fluid analysis on cytology does not show any evidence of a malignancy. There is a note, however, of abundant inflammation and hemosiderin deposition, and strikingly, her fluid crit was 12%. So lots of blood in this pericardial effusion. Here's a transthoracic echo image from after her pericardiocentesis. And you'll see this, very large sort of lobulated mass in the right atrium that extends across the tricuspid valve into the basal aspect of the right ventricle. You'll also note that there's sort of a moderate anterior pericardial effusion that does not cause any chamber compression. But really the main finding here is just this very, very large mass on the right side of the heart. Which produced severe functional tricuspid stenosis with a diastolic mean gradient of 14 millimeters mercury. So she's referred for a cardiac CT, which demonstrates this large, essentially hypervascular mass in the right atrium, which appears to extend into the inferior and lateral aspects of the right atrium. It crosses the tricuspid valve and also appears to extend into the basal aspect of the septum on the right ventricular side. So to walk through her oncologic history, her index presentation, which I've just described, was with dyspnea and chest pain, where she's found to have this large mass and tamponade. Fortunately, there was no evidence of metastatic disease on a CAT scan of her chest, abdomen, and pelvis. She undergoes a percutaneous ice-guided biopsy of her right atrial mass, which shows angiosarcoma, and I'll have Dr. Chandler walk us through the path here shortly. So she is, after this biopsy, she's referred for basically a neoadjuvant chemotherapy with the AIM regimen, which is a standard regimen for soft tissue sarcoma. This stands for adriamycin. The generic name here is doxorubicin, as well as ifosfamide and mesna. So she completes 6 cycles of this AIM chemotherapy and then undergoes a cardiac MRI at the conclusion of this 6th cycle, which fortunately shows a decrease in the size of the right atrial mass. Thank you very much to Dr. Krieger for putting this slide together. So on this this sending image in the left panel, we'll note that there's this large mass basically sticking to the lateral and inferior walls of the right atrium. You can see, based on the index echo and CT images that I showed you, that the mass has, shrunk, quite markedly after the 6 cycles of chemotherapy. On the T1 weighted black blood images shown here in the middle panel, this is an MRI sequence where the signal from flowing blood is sort of suppressed, which basically allows us to look at the myocardium and structures in the myocardium better. We see that this right atrial mass is iso-intense to muscle, which is a characteristic finding in soft tissue sarcoma. And then on the post-contrast images, we see that this mass brightly enhances, similar to blood pool, which makes it unlikely to be either thrombus or muscle. So taken together, all these findings are basically sort of consistent with her tissue diagnosis of angiosarcoma. She undergoes a successful surgical resection with Drs. Corsandi and Gensini. Intraoperatively, they note that the tumor extended from her SVC to RA junction cranially to the coronary sinus caudally, and really came down to the tricuspid annulus and also extended into the atrioventricular groove around the right coronary artery. So she undergoes a resection and extensive reconstruction of her right atrium with a bovine pericardial patch. And then in order to get a sort of a complete, or what's called R0 resection, a bypass graft with a saphenous vein graft to the posterior descending artery is also placed at the time of this surgery. So I'll turn it back over to Chris to walk us through the percutaneous biopsy results as well as the surgical pathology. So I'll stop my share here, Chris, and let you take over.
All right, thanks, Alex. So we're going to start with the biopsy of the right atrial mass. And from a low power view, you can see we've got 2 nice fragments of tissue here to examine. And even from this level, you get the sense that there's a fair amount of cellularity to this, as well as some blood that's apparent. So moving in a little bit closer to take a peek at the actual cells and morphology, a couple of things are apparent from this level. One, we do have what appears to be a proliferation of cells, so certainly concerning for possible neoplastic process. And 2, there's a fair amount of blood that's admixed. Now, given the location within the atria, this is not necessarily unexpected, but in this case actually is helpful. So moving in a little bit closer to take a peek at the cells themselves, get the sense that they are sort of spindled and shaped, elongated, look like they've been stretched kind of along the long axis. And they're fairly haphazardly arranged. There's not anything that looks like normal tissue architecture here. The other thing that's apparent is there's a lot of blood that's actually admixed in with what appears to be this neoplastic proliferation of cells, as well as some spaces that are near the cells within the proliferation. So moving at the highest power, you get the sense that there's these little clefts and gaps, as well as just a fairly pleomorphic appearing population of spindled cells. And notably within these clefts and gaps, and here's one right here, there are red cells. So taken together, the overall morphology in this case is very concerning for a vascular neoplasm, given the fact that it does appear to be a spindled population, something consistent with a sarcoma, and also forming kind of these abortive vascular spaces. Now, morphologically, we're very suspicious that's the case, but we need to actually try to pin down a line of differentiation. So when you have concern for vascular neoplasm, kind of our go-to stain is for a marker called ERG. Now this is a nuclear stain, and it's a very beautiful marker of vascular differentiation. So in this case, if we zoom in, we can see that this proliferation of spindled cells is marking very strongly with ERG, and it's consistent with a vascular neoplasm. Taken together with the morphology, overall most consistent with angiosarcoma. So we'll take a look at the representative slide from the resection, because this is actually a fairly fascinating example of what happens with these neoplasms with treatment. For orientation purposes, this sort of dark pink band here is the atrial wall. This would be kind of the luminal side, and then the adventitial, or sort of the pericardial side of the tissue is here. And along this endocardial surface, you get the sense that there's these big lobulated areas that look a little bit less dense from a cellular standpoint. And this one has some admixed fibrin. So why don't we go in and take a look a little bit closer at this. So again, confirming our low power impression, here's the actual myocardium, the wall of the myocardium with cardiomyocytes. And there's this large kind of amorphous mass with all of these brown specks kind of along this endocardial surface. So if we go in and look a little bit closer at, oops, sorry about that. And what this is, we see these kind of loose kind of fibroblastic cells kind of jumbled around, and then these dark brown areas of pigment. This pigment is consistent with hemosiderin, so it's kind of this chunky refractile looking pigment. And the overall architecture of this is suggestive of treated sarcoma. Now, this is a very challenging case because, again, if we go out to kind of low power, you get the sense that this was a very large mass, and there's a tremendous amount of treatment effect here. So there's sprinklings of hemosiderin throughout here, here, and here. And we're trying to get a sense of, is there any actual residual angiosarcoma? Which is not an easy question to answer. So then again, this is a ERG immunohistochemical stain, which we know the neoplasm is already positive for. And again, our go-to. Very pale tissue because we're lacking the eosin. And as we move in, again, we're looking for brown, which can be kind of a challenge. Some of the brown staining in this is actually the hemosiderin that's being deposited. But we do see actual endothelial cells here that are part of the normal part of the myocardium that are marking with ERG. So we have a nice positive internal control. Long story short, and I'm not going to go through this entire slide, we could not find any areas of residual angiosarcoma in these areas that look like they've been treated, which is a tremendous treatment response. Now, this isn't the present case because it's not nearly as interesting. This is actually a representative gross pathology from an autopsy of another angiosarcoma, cardiac angiosarcoma I was involved in. And you can see this is the right atrial wall here. This is where the kind of lumen would be. And there's this large hemorrhagic appearing mass with some kind of solid areas and areas of necrosis. And even on gross pathology, you get the sense that this is something that might be vascular. So a lot of blood in this specimen. So a little bit more about cardiac angiosarcoma. It's the most common primary cardiac sarcoma. They're almost exclusively right-sided, as are most primary cardiac malignancies. Usually more benign tumors are located on the left, and the vast majority arise in the right atrium. The etiology, again, these are very rare neoplasms, not really well delineated. And we do know that there's upregulation in genes of VEGF. And then they do have fairly complex karyotypes. Most commonly, a trisomy 8 is found, as well as trisomy 17. And then a paper out of Mayo Clinic looking at a series of 10 found a gain of 1Q, which may or may not confer a better prognosis. Again, very small series. So when we see this on pathology, histopathology, gross pathology, you know, our differential diagnosis includes a number of things. Probably first and foremost is this metastatic disease? When we see neoplasms in the heart, they're usually not primary. So again, looking at the morphology, looks like it could be a sarcoma, clinical history. And then in this case, confirming vascular differentiation is really helpful. Well, the etiology, you know, when you have a vascular neoplasm, there's a couple of things it could be. It could be angiosarcoma if it looks malignant, or the other main thing on the differential is this epithelioid-hemangioendothelioma, or EHE. So the morphology, which I'll show a little bit of for EHE, is different than angiosarcoma, and then they also stain slightly differently. So we have IHC against this partner that is one of the disease-defining fusions in epithelioid hemangiosarcoma, CAMTA1 and WWTR1. And then the other thing, which is what we had in this case, is cardiac angiosarcoma. So if we look just briefly at a representative soft tissue EHE. We can see what the morphologic differences are. So again, this is not cardiac EHE, those are very rare. But from a very kind of medium power view, again, we get a sense that there's a proliferation of cells. Some of them look like they could be forming vascular channels. This is very bloody. And if we go in a little bit higher, the main thing that is distinguishing is the cell type is more epithelioid, and there's this sort of blue-gray chondromyxoid matrix, which is very characteristic of EHE and is probably the main morphologic tip-off when you're dealing with these neoplasms. And similar to our case, it does appear to be forming some vascular spaces, and in fact even has areas where the cells might have intracytoplasmic lumens with red cells in them. So there's some characteristic features of EHE. Again, the morphology really distinguishes it from angiosarcoma. So with that, I'll hand it back over to you.
Thank you so much, Chris. Fantastic. Not to overlap with Chris, I just want to talk a little bit more about sort of the epidemiology of cardiac sarcoma and a little bit about treatment before we wrap up. The first is just to take a step back and recognize that primary cardiac tumors are extremely rare, with an autopsy incidence of about 0.002 to 0.3%. And of these, most of them are sort of a benign tumors. About 25% of primary cardiac tumors are malignant. Of these, cardiac sarcoma accounts for about 95%, and the most common histologic type of cardiac sarcoma is angiosarcoma, as was seen in this case. Once again, most common presenting symptoms with cardiac sarcoma are dyspnea and chest pain, the two cardinal symptoms that our patient had in this case. Differential diagnosis really includes metastatic lesions, myxoma, thrombus, lymphoma, and several other exceedingly rare cardiac neoplasms. Imaging, such as cardiac MRI, does help to narrow the differential diagnosis, but tissue biopsy really is required for diagnostic confirmation. In cases that do spread, angiosarcoma, as with other soft tissue sarcomas, tends to spread hematogenously as its primary route. The most common site of metastatic disease is the lungs. Other common sites include liver, bones, soft tissue, as well as lymph nodes. This is one of the largest single center experiences with primary cardiac sarcoma out of the Cleveland Clinic. They recently published a retrospective review of 42 patients with primary cardiac sarcoma. And in this cohort, angiosarcoma was the most common histologic type, representing 21% of cases. As Chris mentioned, most of these tumors were right-sided. This is also seen in other case series. In terms of the demographics of this cohort, there was a roughly equal split between male and female patients, presenting at a median age of 50 years. And the majority of them presented without metastatic disease, which is just how our patient presented in this case. Approximately 20% of patients were treated with combination therapy with surgery, radiation, as well as chemotherapy. The most common chemotherapeutic regimen used in this study is what our patient received, which is doxorubicin plus ifosfamide. And unfortunately, despite treatment, there's really a dismal prognosis associated with this diagnosis. So for angiosarcoma in this case series, the estimated median survival was only 14 months, and was slightly higher for the whole cohort of patients with cardiac sarcoma at 25 months, but still, a relatively, a relatively poor prognosis with this diagnosis. In terms of treatment outcomes, so this is from this same case series. This series of survival curves here basically show surgery and chemotherapy here with this black line. Hopefully you can see my mouse here. Surgery and radiation therapy is this more gray line. And this line here with the best survival is the combination chemotherapy. So patients, or the combination therapy rather, patients who received surgery, chemotherapy, and radiation therapy. So there's definitely a difference in treatment, and multimodality therapy, meaning surgery plus either radiation or chemotherapy, was associated with higher survival in this series than just standalone treatment with surgery, chemotherapy, or radiation. So the goal in these patients really, if they can tolerate it, is to do chemotherapy, surgery, as well as sort of a radiation therapy. Not surprisingly, achieving a complete resection does improve survival in these patients. So this is from a retrospective review of 44 patients presenting with primary right-sided cardiac sarcoma. In this case series, 68% of these were angiosarcoma. And you'll see the survival curves here. So blue shows patients who had negative surgical margins, and green shows those who had positive surgical margins. And not surprisingly, patients who had this R0, so basically, better or a negative surgical margins had a much longer median survival than those with positive margins, so almost 54 months compared to about 10 months. The authors also reported a sort of numerically longer median survival with neoadjuvant chemotherapy, but it was not actually significant with a p-value of 0.417. So I'm happy to report that this patient had a smooth postoperative recovery after her surgical resection of this angiosarcoma. She's currently under the care of the SCCA and is undergoing adjuvant radiation therapy. And the plan is to repeat surveillance imaging about 2 months after she finishes her course of adjuvant radiation. I'd like to thank everyone who helped with this case preparation, including Dr. Moorman, Krieger, Steinberg, and my co-fellow Fitz. I'd also like to thank Chris Chandler for his fantastic overview of the path slides today. So thank you very much. And Chris and I will take any questions about either of the cases at this point.
Well, we wait to see if any questions populate in the chat here. I just want to thank you both for those excellent cases and make a comment about case number 1, which had a lot of teaching opportunities there. First, the finding of the anomalous coronary artery and the myocardial bridge segment illustrates why cardiac imaging can be so important, and one of the potential advantages of ordering a coronary CTA rather than a stress test in a younger patient with chest pain. And also, I want to point out that our sonographers here at the University of Washington do an excellent job always looking for the coronary ostia when they see young patients who are referred for chest pain evaluation. You had that beautiful image of the parasternal short axis showing the anomalous course of the coronaries.
Yes, those are both excellent points.
So it looks like Larry has a question. With the first case, he wanted to be reminded if the left coronary artery coursed anterior to the PA, that high-risk anatomy that you mentioned.
Yeah, thanks for asking, Dr. Dean. So in this case, the patient had a subpulmonic course of that left coronary artery. So it was not an intra-arterial course, meaning it didn't pass directly between the PA and the ascending aorta. So the subpulmonic course is generally felt to not represent a high-risk finding.
Can you hear me?
I see Dr. Linker has a question as well. He asks, is there any relationship between initial response to therapy and survival in angiosarcoma? That's an excellent question. I don't know if I saw any data directly addressing that question. Certainly patients who can tolerate neoadjuvant chemotherapy prior to surgical resection have better outcomes. And that's what that's basically what this patient got. And you can imagine that it probably made the surgical resection a little bit easier because the mass shrunk markedly after her course of chemotherapy.
And I see Dr. Krieger has his hand up, and if I think we can hear you, Eric, if you want to ask your question or make your comment.
Thanks, Alec. Are you able to hear me?
It's very soft. I wonder if you can move closer or.
It's improved. I'm afraid it's probably not going to work.
No, we can hear you now.
Oh, perfect. Okay, so I was going to say with these anomalous coronaries, we generally break the course down using a few different terms, right? We have the intra-arterial course between the aorta and the pulmonary artery. Then we also describe intramural courses, which are ones that run within the wall of the aorta. And then we have this intramyocardial or subpulmonic or intraseptal course.
Mm-hmm.
And that's what this patient had. And it's really, we're really still figuring out what the risk of those patients are. Historically, people had dismissed these as lower risk anatomy and lumped them together with myocardial bridges. Although there is emerging data really from the Texas Children's Group, who's done an outstanding job doing stress tests on patients with anomalous coronaries, showing that these patients actually have a very high rate of inducible ischemia. So it may be that these anomalous coronary arteries that run in between the aorta and the infundibular septum or beneath the pulmonic valve annulus, or these intraseptal subpulmonic courses, are more like the interarterial courses than we previously thought, but it remains unknown. I would lump this patient more with in the anomalous coronary bucket, with an anomalous left coronary from the opposite sinus bucket, than I would probably in a myocardial bridge bucket, because I think that most of the myocardial bridge literature didn't really talk about patients whose coronaries were coming off the opposite sinus of Valsalva. So it's still an area we're trying to figure out what to do with, but they may actually represent a high risk population.
Great. Thanks so much for that clarification. I appreciate it. So I see a few other questions that I can address in the chat here. So one person asks, in the cath lab, it doesn't seem like we have a prevalence of myocardial bridging as high as 40%. How do we explain the possible discrepancy? I think they're referring to the discrepancy between invasive and non-invasive imaging and autopsy studies. And that's a really good question. I think for any anatomic diagnosis, your gold standard is going to be actually looking at the gross path. So actually doing the autopsy. I think small myocardial bridges sometimes are just missed on the angiograms, and it may be if they're in a more distal coronary segment, we aren't looking closely for them. So I think part of it is that, but yeah, I don't have any other sort of kind of like insights into why there's that discrepancy. Another question is from Dr. Stewart, who asks, why has syphilis infection increased since 2000? That's an excellent question, and this is an area of active study by the CDC. As I mentioned on one of the slides, the population that's really faced a sort of disproportionate burden of increase in syphilis infections is the sort of population of men who have sex with men. And the factors there that are contributing to this increase are probably multiple. There's been some literature looking at sexual networks and how those sort of play into the increased risk of syphilis in that population. But certainly an area that warrants further study. Dr. Thompson asks about the Jarisch-Herxheimer reaction with treatment of syphilis. So thanks for bringing this up. So this is a potential reaction that's seen that's from basically these this extensive cytokine release that occurs in response to antibiotic therapy for syphilis. And so this can present with fevers, chills, body aches, things of this nature. Tends to be self-limited. And just in my understanding, usually just lasts for a couple of days. And it shouldn't be confused with a penicillin allergy. That's sort of the main kind of thing to know about it. All right. Well, I think we're coming to the close of the hour here. Thank you so much, everyone, for coming this morning to our Cardiology Pathology Conference. And thank you for the excellent questions and the insights from Dr. Krieger and others. And with that, I think we'll bring this presentation to a close.